Good afternoon. Welcome to Legat Architects Think Tank 2020 Resilience. My name is Steve Bly, and I'm a creative director and associate director of healthcare at Legat Architects. At Legat Architects, we're a design practice specializing in planning, architecture, and interior design. Our firm's portfolio includes commercial, governmental, healthcare, higher education, hospitality, mixed use, pre-K-12 education, and transportation facilities. So a little bit of background about Think Tank. We've been going on about 6-7 years, if I can recall. It's an annual symposium orchestrated by Legat Architects. Each year we invite authorities from a variety of disciplines to speak about trends related to their areas of expertise, as well as how design impacts those fields. Some of our recent topics have been biophilic and sustainable design, health and welfare, school safety, urban sprawl, and many other timely topics. At last year's event, the Think Tank partnered with Chicago Architectural Biennial and was featured on ArchDaily, Bustler, and Architectural Products magazine. This year's topic is very timely, especially considering what we've been going through recently. It's resilience. In ecology, resilience implies the capacity of an ecosystem to respond to disturbance or invasion by recovering quickly, adapting to change, and evolving to thrive rapidly. This also occurs in society as well. In this year of radical change, resilience is imperative to the survival of not just architects and designers and healthcare professionals, but also the human race. And now I'd like to present our speaker in the area of healthcare. Dr. Cynthia Barginere, Doctor of Nursing Practice, registered nurse, and a fellow of the American College of Healthcare Executives, received her bachelor and Master's of Science in Nursing Administration at the University of Alabama, and a doctorate of nursing practice at Samford University in Birmingham. She worked in Detroit for 5 years, raising her kids, and then beginning in 1994, spent 12 years at the University of Alabama Hospital in Birmingham, with a final 4 years as an Associate Executive Director and Chief Nursing Officer. Beginning in 2006, she spent 5 years as the Chief Operating Officer and Chief Nursing Officer at Baptist Medical Center South, also in Montgomery. Then someone convinced her that Chicago climate was great. In 2011, Cynthia joined Rush University System for Health as Chicago as the Chief Nursing Officer and Associate Dean for Nursing Practice, where she oversaw 2,000 nurses and a budget of $165 million. She supervised the Rush Women's and Children's Services and then helped everyone move into Rush's new bed tower in 2012 single-handedly. Then in 2015, Cynthia was promoted to Senior Vice President and Chief Operating Officer also at Rush, working on clinical programs. And under her guidance, in 2016, Rush achieved their 4th designation as a magnet hospital, the highest honor in nursing. So until recently, she was serving as the active Chief Transformation Officer for the Rush University System for Health, responsible for system integration throughout the entire system. She's been honored as a Chicago United Business Leader of Color for 2015, serves on numerous boards, fellowships, and committees focusing on healthcare, nursing, professional networking, and economics. She has 2 sons, 33 and 34, who are musicians in LA. And she's keeping them as far away from healthcare as possible. And now I would like to introduce you to Dr. Cynthia Barginere. Thank you.
Thank you, Steve. And hello, everyone. Thank you all so much for allowing me the time to talk about something that is very near and dear to my heart, which is healthcare design. I have been, as Steve mentioned, I've been in healthcare for a very long time and have been involved in many major construction projects. And the one that I want to talk to you about today is my experience with the Rush System for Health and the opening of the new facility at Rush University Medical Center. And for those of you who don't know where that is, it is on the Eisenhower Expressway, and it is pretty iconic, and we'll see a few pictures both inside and outside as we go along. But thank you all very much for allowing me the time to talk about this. And what I'd like to talk about is we're talking about resilience in healthcare design. I'd really like to talk about this from the perspective of the work that was done at Rush, from the perspective of providing a safe environment for patients and for the healthcare team. I'm going to starting in talking about this, really kind of giving you a little bit of a framework for this. We in healthcare are very, very concerned about making sure that we keep patients safe. And we always have been. But in 1999, around 2000, 1999, a seminal work was done by the Institute of Medicine that really shook the healthcare system up and made us start to think about how do we build a safer healthcare system for the patients that we serve, and actually for the providers that are engaged in the care. This seminal work was called "To Err is Human." And what was shocking to the country was to hear that 100,000 deaths occur in hospitals and health delivery systems related specifically to errors, mistakes, or accidents. Now, I always say that the public were aghast at this number, 100,000. People in healthcare felt like, yeah, it's probably right, because we actually understand the flawed systems and processes within the organization that make it difficult to prevent these errors. And so for people like me who had been in quality and had worked in performance improvement for many years, this was really an exciting time because it got everyone focused on the things that we knew were important. I mean, and this is not about the providers. This is not about people not really caring how they deliver care or being reckless. This is about human behavior and human factors. So, because errors occur when you're performing repetitive and familiar tasks. I mean, if you've ever been driving and all of a sudden came to yourself and didn't remember how you got where you got to, or you made a mistake and slid right through a stop sign because you were tired or distracted, then you know what I mean. These different tasks, those familiar tasks can be impacted by things like interruptions, fatigue, feeling a pressure for time to get things done quickly, anger, distractions, anxiety, fear, multitasking. I am a firm believer that you cannot multitask. And my son reminds me of this every time he's talking to me and I pick up my phone, because he will literally stop speaking to me because he says, you are not listening to me because you cannot do both things. And he's absolutely right. So creating systems that address these things was what the Institute of Medicine was trying to focus on, get health systems and hospitals to focus on. So what is patient safety? The Institute of Medicine has a very simple definition: the prevention of accidental injury and death. The National Patient Safety Foundation also talks about it from the perspective of creating a world where patients and those who care for them are free from harm, because it is not just about the patient, it's about the healthcare team as well. So my time today is going to be focused on how facility design can influence patient safety and support providers in doing the right and safe thing every single time. And it is not just about the facility, but the facility can have a real influence on patient safety and provider safety. And wanted to talk a little bit with you about that today. So one other thing that the Institute of Medicine seminal work did was give us a framework that we can begin to use to build these safety cultures within our organizations. So when we build our quality plan, we use these 6 quality aims. When we start to look at how we can integrate our facilities into the quality infrastructure and plan for our patients, we use these quality aims. So that's what how I'm going to structure this today. Really looking at making sure that as you build a facility, as you build a process, as you build a patient care unit or a system, that you're looking at building it within the framework of patient-centeredness. And it seems odd that you would have to say patient-centeredness, but our hospitals and health systems traditionally have been built, and the systems have been designed based on the providers. And so it really is, they really are very provider-centric. And so we want to make sure that we are being patient-centered in our design. Safety here isn't talking specifically about patient safety, but it's the more concrete traditional way of thinking about safety, and we'll talk about that a little bit later. Effectiveness, efficiency, timeliness, and equity. So I'm gonna begin to talk a little bit about each of these and how we use those in the design of the tower on the Eisenhower. This is one of my favorite pictures of the tower from the sky. This facility opened in 2012. Now, I've been in healthcare for a really long time. So in 2006, I was involved in the design and opening of in 2003, I was involved in design and opening of a major replacement facility at UAB. In 2006, I was involved in the design and development of a women and children's facility. And then at Baptist, as Steve said, we did a lot of facility redesign in that organization. But this, in 2012, was probably one of the most magnificent facilities that I've ever had an opportunity to be involved in. And fortunately, or unfortunately, when I got here, the design had been pretty much done, but I had the pleasure of moving us into the facility, kind of finishing up some of the last minute details and moving us into the facility. So I have a really good perspective on what happened that worked and the things that didn't work. So we moved into the facility in January of 2012. This facility was designed by clinicians, and their focus not only was on patient safety, but it was on the patient experience, creating a healing environment, providing for pleasing views for the patient, because that has been actually in some studies demonstrated to improve healing as well, and to provide for a quiet environment. And if you've ever been in a hospital, or you know how loud it can be, and kind of using the design features to figure out how we would create a more quiet environment for patients was one of the things that was a major focus. But we also were focused on the provider experience. Line of sight is both an issue of patient safety, but it is also an issue of provider satisfaction. When you walk out of the room, you want to know who is available to help you, and you want to also be able to see your patients and be able to know when you are needed in an urgent situation. And so line of sight was a big issue, as well as access to resources, trying to reduce the number of steps that our nurses and our providers actually take in a day. And I actually was able to do some research in that regard after moving into the facility, and found that the facility, based on the design changes, really reduced the number of steps pretty significantly for our nurses when we moved into a new tower, the new tower. So I start out with this picture just because I love this picture. This is one of the design features for the new tower, is that it is on the Eisenhower. And having gone to Rush, I would never say that Rush faces the city, but this is the healing garden that is on the rooftop of the podium of the building. It is available to staff. It is available to patients to go out for lunch or relaxation or rejuvenation. And it is a gorgeous view of the city. And during Wellness Week, we actually had some pretty nice yoga classes, sunrise yoga classes in this space, which was beautiful. So starting with patient-centeredness, one of the things that we were able to do with the new building was to focus on single bedrooms and variable acuity rooms. You know, there has been a tradition in healthcare for patients to share a room. And actually in the Northeast, there are still a lot of hospitals where patients share rooms, as you probably are very much aware. But all of our rooms are single rooms. No patients share a room. That is an issue for patient-centeredness from the perspective of families, but it's also an infectious disease issue, and it's an efficiency issue, because if you're not having to deal with gender, you can have an easier time of being efficient and moving patients and getting them into a patient room from when they need to be admitted. The variable acuity issue is also something nice, and I'll show you that in a moment, but being able to take any room and take care of a patient in that room, regardless of the acuity of that patient, whether they're an acute care patient or they need critical care, is another real feature that we were able to accomplish with this facility. Wayfinding is something that was important in this facility, and we did a lot of work on wayfinding and looking at visual cues within the facility so that you would know that the fourth floor, for example, is our main street, and the colors of Main Street are very different than when you transition from one building to another. We would change the colors on the wall so that you would know that you were transitioning from one building to the other. You know, wayfinding is also on my lessons learned list, and we'll talk a little bit more about that, because I think that we did a lot of work to address wayfinding in this facility. But what we didn't do was talk as much, I believe, to patients and families about what's important for them for wayfinding. So there's a lot of opportunity there. The other issue is family space. And this is a picture of one of our patient rooms. And if you've seen one of our patient rooms, you've seen all of our patient rooms in the tower, because all of the patient care unit rooms look exactly the same. And so when I talk about variable acuity, if you walked into our critical care unit, you would not see a very different picture, except that maybe for the patient, they have a lot more things going on. They have a lot more monitors, they have more, they may have a ventilator in the room, they may have a lot more equipment in the room, but the design is basically the same. You see that the patient area is here, where the nurse's documentation is, and the head walls, so that you have the available gases that you need. And then you have the space for the family, so that they can also participate in the care, because we really do believe that that level of participation is important to healing. So all of our rooms look like this. From a safety standpoint, you know, one of the other things that we focused on was fall prevention. Many of the injuries and harm that is done to patients across our systems relate to falls. And some of it is making sure that, if you'll see it's hard for you to see from the picture that I have of the room, but most of the things in the patient room is on this side of the room. The other side of the room is where the bathroom is. So there's nothing to impede the patient from getting to the bathroom. That is really important, to make sure that if you wake up in the middle of the night, you have a clear path to the bathroom and don't risk tripping and falling. But also looking at the surfaces that we use, the way we design the bathrooms, to make sure that patients fall prevention is a part of it. We also, as far as fall prevention is concerned, had some visual cues outside the room that show that the patient is at risk for falls, which includes a banner on outside the room, as well as light outside the room that lights up to show that this patient is at risk for falls, the yellow light. And there is also the flashing light, because the beds have sensors on them that show if you are at fall prevention or fall risk. If you get out of the bed alarm comes on, and then anyone walking down the hall can see that that alarm has come on, and they can go in and check on the patient. So fall prevention is a major issue. I would love to also point out that Rush is top decile in performance on fall prevention and on falls from a safety perspective, because so much work has been done to make sure that our patients are safe. Beds close to the floor, mats next to the bed in case they do fall, to make sure that they have a soft surface to fall to. I mean, just a lot of work to make sure that we prevent falls, and when falls do happen, that patients don't injure themselves. But there are other safety issues like ventilation and filtration systems that prevent infections. You know, our facility was led by Dr. Larry Goodman for 17 years, who is an infectious disease physician. So infection prevention was a major issue for our facility. So one of the tips of each of our facility, and I'll go back to this picture, we call this a tip and this a tip. And any one of those tips can be flipped to negative pressure when needed. So when when the pandemic hit and we weren't actually sure if COVID was airborne, aerosolizable and airborne, we flipped each of those tips to negative pressure so that we would make sure that if we had COVID positive patients, that we could care for them in a safe environment. Make sure that surfaces can be cleaned and decontaminated, and that the surfaces that we have are the kind that will sustain continuous cleaning and decontamination. Because if you these surfaces have to be cleaned constantly and consistently, and you want to make sure that it is something that is resilient and is going to hold up to that type of abuse, actually. And so also looking at touchless options, making sure that you don't have your staff touching things that they don't have to touch, whether it's wave or foot pedals, to make sure that those things work for the patient. So all of our faucets are wave activated. I do have my funny story about getting ready to move into the building was they wanted to also have wave activated garbage cans, and I nixed that idea because I could just see the nurse standing there all day waving over the garbage can to throw away her paper towels, and I would be getting that call. So we nixed that and we used the foot action for garbage cans. But all of these things are important in making sure we provide a safe environment. Other things like water treatment to prevent waterborne infections. Waiting spaces have become more and more important in making sure that you consider spacing and that you limit guests. And we have places where people can wait remotely. Having hand washing stations and hand sanitizer all over the place. You know, in the hospital, hand sanitizer has always been really important. So we have hand sanitizer outside the door, we have hand sanitizers when you walk into the door, and then we have the sinks easily available inside the door for hand washing. So we have this thing clean in and clean out. So we want you to hit the hand sanitizer before you go into the room. And when you are leaving the room, either wash your hands with soap and water if you've soiled them in any way, but at a minimum, hit the hand sanitizer on your way out. And we have monitors that walk around and watch to see if people are cleaning in and cleaning out. But we want to make it easy for people, so we have those things available. And then a quiet environment. You know, this is really a big issue for patients, particularly at night when they're trying to sleep, and sleep is a major element of healing. And so we did something that for me in my career has been a no-no, but we were able to get the infectious disease team to sign off on it, and we put carpet on the floors. And it is amazing the difference that having carpet on the floors makes in the quiet of the unit. We have one unit in our hospital that does not have carpet on the floors, and that is the bone marrow transplant unit. And it is amazing when you go from one unit to the next, how different the sound is and how much of a difference it makes in the environment. We also wanted to make sure we had space for concentration space for high risk activities. Talked earlier about risks being associated with doing repetitive procedures, even if it's something that you are highly skilled at in an environment where there's a lot of noise, there's potential distractions and disruption. Med preparation is a great example of that. In the old facility, the med rooms are in the hallway. So you're preparing your meds and people are walking by, people are talking, patients are being rolled by. People may walk up to you and ask you a question while you're in the middle of this high risk activity. In the new tower, all of the med rooms are behind a closed door. There's no other activity that goes on in that room other than medication preparation. And we have 2 of those medication rooms on each tip to make sure that no nurse is ever feeling pressured because the nurse is waiting to get to the med room. So there was a lot of expense that was associated with that, but we felt that that was a patient safety issue that really needed to be, to get a lot of our attention. From an effectiveness standpoint, looking at lighting and visual performance, this is a space that's one of my favorite spaces at Rush, and this is our entryway in the pavilion coming into the tower. This big feature here is open to the outside. There's plants and trees in here and greenery. And when it snows into here. And we have events in this space, but you see patients and families standing around here and just looking at this and admiring it and admiring the light and the space. And I think that it is really a great space for families and for visitors and for staff, to be honest. It's a great space. The next issue, is around efficiency. And really in the area of efficiency, we focused on standardization in layout and standardization in equipment. And that goes back to the patient rooms and minimizing transfers and with the variable acuity rooms. You don't have to move a patient when they get sicker because you can care for that patient in the same space. And this is a little bit of more of a close-up view of the patient room. Every patient room has this family space. Every patient room has this patient chair where the patient can sit up, and is designed exactly the same way. And every patient room has a beautiful view, whether it's of the east side of Chicago or the west side of Chicago. It is a gorgeous view outside those patients' rooms. And then also from an efficiency standpoint and a standardization standpoint, all of the units look the same. Now, on the flip side of this, it was a challenge for me the first few years and I do say years we started working in the building, because I never knew which unit I was on when I stepped off the floor, because they all look the same. But that is beneficial, and people get to understand these visual cues that were built in. Although they seem subtle, when you work in the environment for a while, they make perfect sense to you. So these corridors are all the same color no matter what floor you're on, so you know that you are on a patient care unit. This blue carpeting space here really is a provider space. And so this is where we don't have a traditional nurses station because we want the staff to be dispersed and near their patients. So this is patient care space. When you're looking down this hall, this subtle change here on this wall on each side tells you which side the patient rooms are on. So when you are looking down the hall, you know what side the patient rooms are on. And this is the core space, and there's no patient rooms on that side, and it looks a little bit differently. Inside each of these little cubbies is a space for the provider to sit with their computer, a computer, and they can see in the patient's room sitting there while they document or catch up on other things. Also inside this little cubby is a standard cabinet with all of the most frequently used equipment that the nurses and physicians would need, whether they're in the ICU or on the floor, that we have delivered to these spaces each morning so that they have the resources that they need. On this side is the medication room that I spoke about, and the supply room. And the supply rooms are exactly the same no matter what floor you go on. The equipment is in the exact same places. Some units require slightly different equipment because of the patient population that they have, but for the most part, it is standardized across all units. So if you happen to be a physician who is working on taking care of patients on multiple floors and you come to a different unit, you don't have to ask a bunch of questions about where is whatever, because you can pretty much find what you need because of that level of standardization. One other thing that I wanted to just talk about in terms of efficiency is this lobby space that we have. Now, this is a continuation of the lobby space that I showed you earlier in the tower. The lighting here, you can see, is magnificent. So, you know, if you're an employee or you're a patient or family coming in, it's a beautiful space to walk into. The lighting is very inviting. But this space is also very functional. And you'll see these columns that show up throughout the space. Inside the columns are head wall gases. So this space was designed also thinking about a disaster and disaster preparedness, and making sure that from an efficiency standpoint, if we needed to surge in terms of patient volume and we needed additional space to care for patients, we could turn this lobby space into a patient care unit, because there are gases in each of these head walls. And so if we needed to take care of a ventilated patient here, if we needed to take care of an acute patient that just needed oxygenation, we could do all of that in this lobby, which gets to really thinking about disaster preparedness, but how are you as efficient as you possibly can be in those situations, and can move quickly to care for patients under those circumstances. And during the height of the pandemic, this space was actually built out. We brought cots down, and would have been able to turn this into a patient care area had it been necessary. The next element that I'll talk about is timeliness, and that really gets to ensuring a rapid response to patients' needs with code lights, reduction in the number of steps by providers I talked about, and then electronic check-in. One of the things that was really an important element was this issue of a rapid response to patient needs with the code lights. So for that, I'm going to go back to this picture of the patient care unit. When you come into the patient care unit on this end, because this end of the tip is going toward, is a dead end, but this is where people actually come in. So if you get off the elevators and you come to this unit and you're coming to care for a patient who has a code, who is coding, who has an emergency, you want to know which one of these entrances you should go to, or if you should go to the other entrance. And so we initially, and this is part of my lessons learned, we initially thought, well, we'll have the lights outside the door, so the providers will know where to go. They'll know that this particular patient has an emergency. But we didn't think about the fact that when you needed to know which tip to go to, and even before you got to look down the hall. So we had to install these visual cues at the top of each of these tips. So when you walk onto this unit, you know to go down this corridor or that corridor and can quickly get to the patient in a timely fashion. So that was one of our lessons learned, and I think one of the really cool features in this facility. As I talked about reduction in the number of steps for providers, we did an actual study of the steps that nurses took prior to moving into the tower and reassessed after we moved. And we were able to significantly reduce the number of steps that nurses took going to and from the patient room, because things are very compact and everything they need is on that tip. So if you work on this tip, you have access to the med room, you have access to the patient, to the utility, clean utility room, you have access to the dirty utility room and your supply room, and you can access it on either side wherever you are in the building. The other element, and the last element, is really that of equity. And really looking at size, layout, and function, meeting the diverse needs of your patients, and making sure that whether it is a critically ill patient or an acute care patient, that you have the same care opportunities and options for all of those patients. I think that also gets to really part of what we wanted to do when we wanted to have all private rooms, because we did not want to have to make a decision about who gets a private room and who gets a semi-private room, because that does, for patients, feel inequitable. So having all private rooms gives everyone that same level of comfort. Really looking at high-tech and low-tech options for patients and families, making sure that they have ways to engage and interact in both ways, both high-tech and low-tech. Inviting spaces that support diversity and inclusion, making sure that, for example, the pictures that we use throughout the organization are culturally sensitive throughout the organization. And then, you know, we have a pretty diverse workforce in terms of generations. So this also gets to the high-tech and low-tech options, making sure that if you know, some people can use small devices, other people need larger devices in order to be able to see these, the medical record, and, you know, having monitors up on the patient care units that everyone can understand, that you don't have to be a provider or a healthcare provider to understand the boards, the status boards that are up across the organization, and that there is easy to understand regardless of your education level or your status. We also had the issue of having this brand new iconic space, but still having patient care delivered in the older space. So it took us a few years, but we actually embarked, as soon as we opened the tower, embarked upon the work of retrofitting the older space. And these are some pictures of our pediatric space after it was renovated. But one of the big issues, and I remember the head of the hospital at the time making the point that we were going to invest the resources that were required in order to make people feel that their experience was the same regardless of where they were on this campus, and that you wouldn't feel like, you know, you had gone to, you know, because you were not a surgical patient on the units where the surgical patients were cared for in the tower, that you were not as important from a patient care perspective. So we retrofitted all of the space in the other two buildings after, it took some time, but after moving into the tower. So we did have some lessons learned. As I said before, on the code lights, we did not install those code lights initially, but it was value engineered out of the project. So we did have to go back and redo that. Another thing that we had to go back and redo was the tube system. And, you know, the tube system is really, really an important support for the providers, and it can be a very high stress issue for providers. The tube system that we used was very high tech. It had a lot of abilities, and so we pushed it to its limit. The thing that we made some assumptions about how providers deliver care. And so we had on-stage and off-stage areas. So we put the tube system outside of the patient care areas. And the assumption was that when an important product came up, like blood or medication, that the nurse would be paged, and then within 2 minutes, she could go out and get this important product from the pharmacy or the blood bank and bring it in to the patient care unit. What we didn't realize and didn't pay enough attention to was how much time is 2 minutes. Because 2 minutes is not enough time. And so we had all of these, if you're in the middle of something, and I always say when your hands are in something, it's not always something that you can walk away from in order to go and get something from the tube system. Even if you're in the middle of a sensitive conversation with a patient or a family member, you can't just stop because you got a page. So we had a lot of situations where the blood would come. If it had been there, it was a secure delivery. So if it had been there for 2 minutes and no one had picked it up, it would turn around and go back to the blood bank. The nurse would go out to get it. There's no blood. They got to call the blood bank. Please send the blood back. I didn't get to it in time. They sent it back again. We call those flips. And we were actually counting the number of flips we had coming from the blood bank and the pharmacy, and the delay in treatment that created. So we actually did an assessment and made the decision to move the tube system into the patient care area behind the unit clerk. That probably cost us about $200,000 or $300,000 in order to do that for the entire organization, but it was really necessary, and it was a good lesson learned for us. Another issue that we learned from, and actually I had the same experience when we did the renovation for UAB, is that when we think about adult services and we think about replacement services, sometimes we forget that OB we typically leave OB for a later time because it's so complicated, but we sometimes forget that it is an emergency service. So our OB and our emergency department were a good distance apart from one another. And it was, they were on the phase 2 in terms of their move to the new building. It was always planned for them to move there, but they were not planned for the initial move. So we had to put a lot of temporary processes in place to make sure that we kept our OB patients safe during that 1.5-year time period before we moved them. If I had that to do over again, I would make sure that we were moving them all at the same time. But only because it was very resource intensive to make sure that we kept patients safe, but we were able to keep all of our patients safe. It was just very resource intensive. I think an overdependence on technology is something that you have to kind of, will yourself to hold back from. My example in this facility is we made some decisions to use the little, I never remember what they're called, these little people mover kind of things to move equipment across the facility, which worked perfectly. I mean, they come up, these little robots, they bring equipment up to the elevator and come up on the elevator and drop it off in the utility room so that people don't have to move all of this supplies throughout the organization. We also that was really a great thing. Now, what we did with trash and linen is we decided that we wanted to also reduce the number of people who had to move trash and linen. So you put the trash and linen in this tube system that sucked it across several blocks to take it to the dock. And it is to this day still a challenge because it is always going down, because trash does not need to move at warp speed. and it doesn't really like moving at warp speed. So there's always some issue with the trash. So if you're ever thinking about creating a warp speed system for your trash, just let people move your trash. We could have spent more time on user workflow design. As I said before, the issue of co-location of services, the issue of the lights for codes, all of those things are things that if we had maybe done more following of the provider and watching and their workflows and really mapping out their workflows and really redesigning those workflows based on the new design, I think it would have helped. And it would have helped to prepare the staff for the changes, because you would be surprised at the number of staff that were just completely disoriented moving into this beautiful, wonderful space. And some of them were not real excited about it because it changed everything and how they did their work. And we didn't take the time to give them the time to spend time in that space working through those workflows and getting used to them. Even with, we could have even done that with, and we have done since that, with temporary space, to give them just an opportunity to simulate some of the new systems and processes and new workflows. I would say making sure that food options are available is another opportunity that we maybe missed on. Nothing is more important during people's really short breaks than being able to go someplace and relax and have food. So don't underestimate that. And then, as I talked about earlier, the line of sight for in the ICUs. And I make this point about the ICUs specifically because this is another example of a room, but it doesn't have anything in patient care unit. When you say line of sight and you look down this hallway, I can see very clearly down each of these, but what you can't see are the patients. And in most ICUs, you have glass doors and you can see. And if you are sitting inside this little cubby here, there's a cutout on the door where you can actually see the patient. But if I were designing an ICU and thinking about line of sight, I would want to have a broader line of sight, being able to see the patients. And so if I could do anything differently in this tower, that would be one of the things that I would do. So what are some of the things that I think maybe in the future to consider as, for myself, if I'm thinking about as an executive working to build a new facility, or if you're working with other leaders to build a new facility, the kinds of things that you might want to think about. One being the toe-to-go elevators, which I am just learning about, which I think is the coolest thing, so that people don't have to touch the elevator. Even myself today, I think about, the elevator and being able to not have to touch those buttons. I think equipment and furniture disinfection, making sure that your equipment and your furniture can withstand the torture of the disinfection, because it has to be done, but you really have to have some furniture that can withhold and uphold the look, and it's can withstand the harshness of the chemicals. We've talked about we hadn't talked about telehealth, but not in the hospital per se, but in some of our ambulatory settings, we have created spaces for hoteling support, and we don't have spaces for physicians to have their own private offices in those patient care areas, in those physician clinic areas. So space for telehealth, it becomes an issue because you want to have them someplace where they can have the quiet and can not be distracted while they are talking to patients using telehealth. So having that balance between hoteling support and space for telehealth is something that I think we really need to think about going forward, because we will be doing more and more televisits. And you don't want to have to use an exam room for that because it reduces your efficiency. So making sure you have space for that. I've talked about the visual cues. I think that is so important, not just for patient care, but even as you're designing the kitchen. How do you make sure that you have visual cues that show exactly where different equipment should be and where it shouldn't be, and that you're making sure that you're keeping the space used appropriately, and keeping our patients safe. Outdoor space and having natural light is also really important. I cannot tell you how much people love the healing garden, and how much people love the other outdoor space that is available. During the few months that we have a beautiful weather here in Chicago. I actually was in a facility out in California a few weeks ago where they actually were using their outdoor space even for physical therapy. So these are just a few of the other things that I feel are important for the future. I'm not going to read them to you. You can see that. I think probably of this, the most important thing is engaging your customers and your patients in your design, and making sure that we are focused and being patient-centered in our design. That will help us to make sure that our providers are able to do the right thing and the safe thing every single time. So that concludes my presentation. And so I'll turn it over to Steve for questions.
Thank you, Cynthia. I have heard many presentations in healthcare, and I wrote down at least a dozen things that were things I want to ask you about later. It was extremely useful information.
Great, great.
About 7 or 8 minutes for questions. And one of the questions is, in your various roles at several hospitals, what issues would keep you up at night? You couldn't sleep because of something you were worried about.
Oh, wow. Well, I think that probably the first thing that keeps me up at night is staffing, and making sure that we have the right staff in the right areas for the right patients. That's probably the one thing that worries me the most. And that, you know, as a chief nurse and as an operations person, really making sure that we are, that we have the right numbers of people, and that people are properly trained to do the work that they are required to do. It's probably my number one.
Okay. Very good. I mean, if you have anything else you think of, let us know. So you were involved in the design, but probably it was laid out already with same-handed or mirrored patient rooms. There are some people that say that the research does not require same-handed patient rooms, and others that believe in it really strongly. What is the layout of the patient rooms in your own hospital, and what drove that decision? Was it cost, safety, or something else?
So when you say same-handed, you're talking about approaching a patient from the right?
Always on the same side. You walk into a room, and every single room is identical and not flipped.
So this is a controversial issue.
Yeah.
So I have spoken to many physicians who do not necessarily think that that is important. And I have not spoken to nearly enough physicians to convince me that it is that important. What I will tell you is that it is a significant increase in cost for the organization. And unless there's some really strong evidence out there that demonstrates that this is a critical issue to patient care and patient safety, I don't know why you would spend that amount of money. And you know, the other thing is, it does impact line of sight in the ICUs, because now you can't put people's feet to feet. And so I can't put a glass door between the rooms. And the best designed ICU I have ever worked in was when I worked at UAB, and they had breakaway doors between the rooms. So if I'm taking care of 2 patients, I can see both patients while I'm in the room. And I can get to that patient if I absolutely have to. And you can't do that either with that same hand design. So I have not found, and this is one girl's opinion, but it is a researched and informed opinion. I do not think that the cost supports that design. And yes, Rush is same side, same hand design, and I did not have an opportunity to have it inputted.
Oh. Say Rush does have the same side design. It's not mirrored.
Oh no, it is mirrored. Well,
it is mirrored.
Yeah, you approach the patient from the same side each time.
And in case somebody wonders why it's more expensive, if you have a single area where the toilets are coming up and they're back to back, you're saving a lot more money than having it go up at every room.
Head walls too, head walls and gases.
And gases, head walls and gases, a lot more money when you can't back them up.
Yes.
Back to back. Another question, how has COVID changed health, safety, and welfare standards for patient spaces and care? And what would you think that designers should consider for designing around pandemics in general and COVID in specific?
Well, I think the idea that you can flip to the air handling, the ventilation, and the ability to flip to negative pressure is a really important element. I think we're going to continue to be to struggle with these airborne illnesses, and we just don't know enough about them. And so when it used to be an occasional TB patient, so having negative pressure for a few rooms in the organization was sufficient. And let me just point out, depending on the type of organization you're in, even the numbers of negative pressure rooms that we had were not sufficient from an efficiency standpoint and being able to really get the beds when you needed them. So that is something that I think is worth the cost, and particularly going forward. I have this feeling that, I've been doing this for a long time, so I remember when universal precautions were put in place. Universal precautions were put in place for bloodborne illnesses. I think we're going to have this next wave is going to be universal precautions for respiratory illnesses. And I think that this is going to be an important design element going forward.
Very good. We got another question for you. We all know that it is the best use of a caregiver's time to spend maximum time with the patient and interacting with them and not doing all the other things that get in their way. What are some of the methods that you can think of that would help allow you as a caregiver or your staff as caregivers to spend more time with the patients and less time with charting and walking and delivering and answering lights and all that?
Well, I think that Rush did an amazing job of reducing those extraneous things that nurses and physicians have to do by making sure that the servers were outside the door. If I were to redesign the servers, I would have them be able to access them from inside the room instead of having to come out of the room to get to them. Maybe having the ability to access them either way from an efficiency standpoint. But having those servers outside the rooms is a tremendous savings in time for the nurse. The other thing that I love about Rush, which was also pretty expensive, was having having 2 medication rooms on each unit, allowing staff not to have to wait and walk back and forth because the Pyxis machine is not available. So now you go do something else and then you come back and then somebody else is in line and then you come back and the 30-minute window that you had to get your medicine to the patient on time is already lapsed. And so I think having things near where, that equipment and that support near the patient is important. For documentation is much more complicated than the facility piece. What we did at Rush, though, there's a computer in the patient room. There's a computer right outside the door. There are computers in the patient and the employee workstations. There's computers in the conference rooms. So wherever you are, you have easy access. And I think that the tap and go badges make it easy for you to sign on quickly, so you don't have to start all over again, and it brings you back to the same place that you were before. Those are things that help with the documentation piece. There's a lot of more fundamental stuff that has to happen with documentation to really make providers happy with the clinical documentation.
I am so sorry, but we are out of time, and that was great. I want to thank Dr. Cynthia Barginere for spending this time with us and answering these great questions. I'd like to encourage all the attendees to save their questions for Friday's roundtable discussion and email questions to Justin Banda, jbanda@legat.com. In the meantime, I'd like to remind you that if you want to receive AIA learning units for attending, just send your AIA numbers and email address to Justin. And as of right now, we have collected $1,680 for the Leukemia and Lymphoma Society. You can continue to contribute throughout the week. Please come back tomorrow at the same exact time at noon for day 2 of the think tank. And thank you to everyone for joining us in Legat's think tank for 2020. Thank you. Goodbye.
Thank you.
Thanks, Cynthia.
Thank you.
Thank you.